Hello everybody, I'm Dr. Fuad Khan. Today I'll be talking to you about co-occurring disorders. The idea is to enhance the understanding and skill level of our team members. This is one part of several trainings that our team has put together. I hope you will find it helpful. Now let's begin. So first of all, let me clarify that this is not an absolutely detailed academic discourse. Most of the content has been taken from different studies, but the idea is to just give you reasonable information that's helpful in organizing your thoughts about thinking about co-occurring disorders from a perspective of their relatedness to each other, the concept, the pathophysiology, some words on epidemiology, and then the discussion on association and some approach to treatment. So, starting with the nomenclature of the concept of co-occurrence. Many different terms have been used. They pretty much mean the same thing: comorbid, concurrent, dual, coexisting, or dual pathology. The idea is that they exist in the same time frame, not necessarily anything else. So for example, if from birth to old age or death, you have a time course when you developed a psychiatric illness and a substance use disorder at the same time, the time period where they overlap is the period when you will call that the patient suffers from co-occurring disorders. And in essence, it's a temporal relationship only and not a true causal relationship. Remember, one major complication is that psychiatric illness, or psychiatric diagnosis rather, are based on phenomenology. And various presenting signs and symptoms in various forms, in different clusters, may end up becoming a different diagnosis. Now, in medical disciplines mostly, and substance use disorders, etiology is a bit more clear. What drug caused the set of signs and symptoms? So they're not very much apples to apples, psychiatric diagnosis and substance use disorder diagnosis. Anyway, let's talk about the substance use disorder and mental health disorders together. So if you were to look at the substance use disorders, you can see a cluster of them here. And the psychiatric illnesses that are typically very much associated with them in the co-occurrence pattern include these ones that I've listed: the conduct disorder, ADHD, bipolar, schizophrenia, depression, panic disorder, anxiety disorders, and antisocial and borderline personality disorders coming from the cluster B. From an epidemiological perspective, you can see that younger the age, higher the risk of co-occurrence, especially the use of substance use disorder independently has a high risk in younger age. The National Survey on Drug Use and Health Data, presented by SAMHSA in 2013, compared ages 18 to 25 and ages 50 plus. The patients were those who had a past year of mental illness, and you can see that the substance use disorder in those with the past year of mental illness was way more in the ages between 18 to 25 as compared to 50 plus. Roughly around 35% in one and 9% in the other. Males have a slightly higher chance of co-occurring disorders, and just a slightly higher chance, and anxiety disorders and personality disorders have a higher chance of substance use associated with them. Now remember, young age is a wonderful time. This is the time when the cortical circuits, the executive function circuits, and other limbic circuits are maturing and shaping. And reshaping of these circuits because of trauma, persistent trauma, severe trauma, exposure to drugs, and other environmental factors can set a precedent for increased proneness or disturbance in the future. Now, various studies have shown that roughly 50% of the patients with substance use disorder will have mental health disorders, and mental health disorders, 50% of them will have substance use disorder. So SAMHSA pretty much says that dual diagnosis is an expectation, not an exception. Over the last several years, we have developed more and more understanding of mental illnesses and substance use disorders. However, research about the association of the two remains a major challenge, and our knowledge is still evolving. Now, looking at etiology, everything is really multifactorial. Genetics means direct effect of genes, whereas epigenetic means how the body reads the genetic information. And as the environmental factors influence the human homeostasis, the genetic information may be read differently. Thus, we're probably settling for the concept of multifactorial proneness rather than a clear-cut straight line from genetics or environmental factors. So now let's talk about how scientists or clinicians would tie the concept of some emotional domains to the brain. It's basically done through defining these domains and tying them to some neurotransmitters, neurohormones, and modulators. So 4 of the domains would be reward, decision-making, impulse control, and emotional reactivity that are sort of pertinent to the discussion we're having. Another way to think about them would be Paul Ekman's 6 basic emotions domains, or domains, such as fear, anger, sadness, disgust, happiness, and surprise. Now, let's move on to thinking about neurotransmitters. Let's broadly divide them into 4 major categories: excitatory, inhibitory, neuromodulators, and neurohormones. Remember, when we say excitatory or inhibitory, we are saying that this particular neurotransmitter excites the next neuron in line in the circuit. Is not really exciting the whole human being. So you probably know a lot of these, such as glutamate, acetylcholine, histamine, dopamine, and you can see that dopamine is in both places. It is a neuromodulator as well as it can excite, and similarly you can see norepinephrine in a couple of places as well. Now let's move to a quick discourse on the human anatomy vis-a-vis all these neurotransmitters. So take a look at this model of the limbic system. We're going to talk about the limbic system. The limbic system is the main system responsible for our feelings, controlling memory, emotion, behavior, and as you can imagine, all of these things are interconnected. The hippocampus is like a computer which transfers whatever is being held in our mind into our memory banks. Pretty much like, when a computer writes what's held in the RAM to the hard drive. This area is constantly active, producing new cells and new circuits as memory is being laid down. Now, amygdala are 2 small almond-like bodies on both sides that play a central role in emotional response to pleasure, fear, anxiety, and anger. Through its connections with the hippocampus, it connects the emotion to the memory. The greater the intensity of the emotional event, the stronger is its attachment to the memory, and the stronger is the retrieval of that emotional part of the memory. If dopamine is increased in this area, it can improve the activity first initially by enhancing memory, but that can go on to add fear and anxiety, which is inherently based in the past if it existed in an intense way to begin with. Now, cingulate gyrus plays an important role in connecting memories to the emotional experience and to smells and pains. The small little body called the nucleus accumbens and the ventral tegmental area, these are connected through the pathway that you might have heard, which is called the mesolimbic pathway, and it is predominantly dopamine pathway and is associated with pleasure and reward. A dysfunctional reward system here may mean that people will have to get another way to get the dopamine system going. The prefrontal cortex, or more precisely, the medial prefrontal cortex, handles the executive functioning, thinking, planning, anticipating future, developing ideas and plans, and then preparing for the execution of that plan is done here. This area is highly important, and when disturbed, especially in growing children and youth, by the overflow of emotionally intense experiences coming from the rest of the limbic system, it can lead to abnormalities related to the executive functioning, such as impulse management, consideration of alternatives, delay of gratification, frustration tolerance, persistence, and motivation. Lastly, the basal ganglia are small bodies that are responsible for movement, for repetitions, and somewhat for attention, and they have links into the reward behavior. Now, the neurotransmitters of the limbic system are intricately connected to the human emotional response. Many things can be discussed, but just for some examples, take a look at stress. Stress can induce a response in the body. Acute stress will have a different type of style than chronic stress. Acute stress can start the autonomic nervous system or can start the HPA axis, the hypothalamic pituitary adrenal axis. So, for example, the hypothalamus would release the corticotrophin releasing hormone, also called corticotrophin releasing factor, that will get the anterior pituitary to release the adrenocorticotrophic hormone, which will end up having the adrenal glands release cortisol. Cortisol in the bloodstream will give negative feedback to reduce the CRH secretion. Now remember, with continuous, persisting, or very intense trauma, this whole overdriven circuit can start to readapt and will have either blunted responses or will have exaggerated responses. So early life trauma, inattention, persistent trauma, it puts a lot of burden on the activation of these systems. They readjust into what we may call a maladaptive or a dysregulated pattern. A few words on some interesting neurotransmitters. Going back to our slide, glutamate plays a role in synaptic plasticity and associative learning. Stress and cocaine both can affect its release from prefrontal cortex. There's evidence that in medication-naive individuals who have social anxiety, they also have elevated glutamate levels in their cingulate cortex. A glutamate release inhibitor, riluzole, can decrease anxiety in such patients. Regarding dopamine, which is a very interesting neurotransmitter and is involved in a lot of illnesses and such as ADHD, such as schizophrenia, and many others, there is evidence that excessive use of dopamine enhancers will lead to cellular adaptations. And when those cellular adaptations occur, the intrinsic natural reward system of the dopamine pathways in nucleus accumbens may become dysfunctional. It may promote drug-seeking behavior. And this drug-seeking behavior to enhance dopamine that is now otherwise deficient will just further promote and reinforce that behavior. Dopamine dysfunction is also dysfunction can also interfere with cognitive abilities. People may have difficulty choosing alternative behaviors, which in otherwise normal individuals are easier because they're driven through the natural endogenous dopamine-based reward response. Other interesting things are the monoamine systems, monoamine neurotransmitters, which include dopamine, norepinephrine, and epinephrine. We all know that cocaine and amphetamines will stimulate them and overdrive them. Another interesting neurotransmitter is GABA, or gamma-aminobutyric acid. And it is an inhibitory neurotransmitter and very much involved in anxiety. And we all know that alcohol and benzodiazepine molecules predominantly affect the GABA receptors. Like I mentioned before, prenatal life, infancy, childhood, and adolescence are critical periods where the process of forming a matrix of adaptive stress responses are characterized by high plasticity of the stress system, and if gone wrong, it will increase the vulnerability to future maladaptive responses to stress. So people will have post-traumatic symptoms or have heightened emotionality, emotional reactivity to things that may not be that much sinister or dangerous, and their responses are not balanced. Other examples include, things like melatonin affecting sleep, and, hyperarousal states like startle responses, anxiety attacks, vigilance, they're all connected to norepinephrine. The endogenous opioid and cannabinoid receptors are also being studied to find out their relationship to anxiety, pain, and other bodily functions. Now let's talk about the association. Let's raise some question. Is it true that they are actually associated? What is self-medication hypothesis? Is there evidence? What is deviance proneness? Why some youngsters mature out and others don't? Do substances unmask a clinical illness that may not have precipitated if they were not using that substance? And finally, do substances actually cause a mental illness? So the first one, yes, they're very closely associated. We are again not saying causal or in any other way except co-occurring. In fact, some studies show that anxiety and impulse control disorders have preceded substance use disorder by almost 10 years. With the self-medication hypothesis that certain people will actually treat their emotional state by some specific substance, this has actually never been able to be proven either. There is more evidence that suggests that there's a proneness which will do both the things. So the anxiety or depression as well as the addictive state. Now, what is deviance proneness? Why do some kids go on to have delinquent and reckless behaviors and others will grow out of it? There is some evidence that it is likely related to multiple factors, and some of them are very clearly known and they're interesting. For example, family and parental alcoholism, poor management or under control of behavior, illnesses like conduct disorder, and neurocognitive deficits such as ADHD, learning difficulties, dyslexia, etc. And then finally, disturbed interpersonal relationships with parents, peers, and all of people around them. That can almost predict that people who experience them to an intense degree early on in their life develop negative experiences. Those negative experiences lead to maladaptive coping skills, and the maladaptive coping skills lead to further negative experiences. So it becomes a perpetual cycle of experiencing worsening the perception and the perception worsening the experience. So very important that when we have such patients, we do really carefully look at them in a history collection or data collection way to look for these things. Now, do substances unmask mental illness? The evidence is still inconclusive. The most common one that we hear about is marijuana unmasking schizophrenia. There are contradicting studies. Some of the studies say that high potency marijuana, high use in younger age may increase the risk of developing schizophrenia and in fact even bring it on earlier as much as 3 years. Other studies challenge it. They say that some of the things that you notice in patients who will go on to become schizophrenics, that is, premorbidly, they do have more evidence of social phobia, panic symptoms, and OCD. And perhaps all of it is related to a deficit or problem which also includes the endogenous cannabinoid dysfunction. So, whatever the main issue may be, you may see that these people tend to use more marijuana because they also have an endogenous cannabinoid malfunction. And the collection of those things is producing both higher use of marijuana and incidence of schizophrenia. Alcohol has been implicated in worsening depression. There is some growing evidence that genetic factors are also linked to some externalizing psychopathologies. So, for example, people with impulse control disorders and antisocial personality disorders, they all have a tendency to have reckless or persistent reckless behaviors. And this may lead to that dual pathology. I'll have a little slide right after the fifth point. The fifth point is, do substances induce or begin or cause a mental disorder? This again is inconclusive. And again, the problem is that there are substances who will create, when they're used, they will result in symptoms that look very much like a original psychiatric disorder. So it's that way DSM has included diagnoses such as substance/medication induced disorders. For example, substance/medication induced major depressive disorder. It is also true that many substances will present with symptoms that mimic those psychiatric syndromes, such as if you take cocaine, you may appear manic, or if you take too much marijuana, you may appear psychotic. Studies show that if people become abstinent or go off of these medications, there will be improvement. Now, if there's no improvement, it is perhaps there is an underlying pathology that is separate from it. The question is, what is this whole concept of how long do we wait before we say the substance has lost its effect? Currently, DSM talks about 6 months of wait time. The question is that, is 6 months good for every drug? We don't know the answer to that. Another important thing is that psychedelic drugs have been actually shown to never directly produce any psychiatric illness. Yes, they create a havoc and create a myriad of psychiatric symptoms, but even the diagnosis of HPPD, which is the hallucinogen persisting perception disorder, that has been questioned as being related to excessive use of hallucinogen. It is also proposed that it may just be another underlying mental health disorder with some kind of a deranged system that led to increased use of hallucinogen in addition to finally getting the HPPD, very much like the schizophrenia and marijuana dialogue. You can see in this next picture the concept of what Dick and Agrawal have proposed. They think that they're proposing that there's genes that are directly connected to externalizing psychopathologies, where patients with that kind of a genetic proneness will have more chances of alcohol dependence, drug dependence, conduct disorder, and antisocial personality disorder. So, our take-home points. Presence of mental illness will increase the severity of substance use disorder and lead to more complications, such as relapses, hospitalizations, and higher utilization of services. One co-occurring disorder, if untreated, is likely to lead to the increase of the other. The causal or influencing associations remain unclear. Substance use will present and mimic a psychiatric illness or may cover a mental health disorder. Now we will move on to discussing some treatment. Let's talk first about some treatment models. One of the treatment models is the sequential serial model, which says you treat one first and then you take the other at task. There's two opposite arguments. One says, if you have substance use disorder going on, there will be no ability of the patient to really engage in therapy or pharmacotherapy. The second opposing argument is that if you don't manage the mental health disorder, the patient's chance to adopt an alternative coping strategy will be very much a challenge. Now there's the second model, which is the simultaneous and parallel model, which basically means you're working on both of them. However, it is that the patient remains in charge and it's the patient's burden to manage the two systems. There's treatment going on, but there may not be crosstalk. And even if it is, it still is patient's burden to give all the release of information and connect them and all of those things. The integrated model is a high efficiency and much better model in which it is a complete integration, and the system drives the link. The system is responsible for making the connection of all the parties delivering care to the patient. The integration is also not just psychotherapy or pharmacotherapy of the two disorders, but also includes a whole gamut of other things that may influence recovery, such as overall health care, housing, employment, social services, and skill development. So in conclusion, the research clearly shows that if you neglect to treat one of the two disorders, it can increase the risk of relapse in the one that was actually treated. So if you have a patient with substance use disorder and depression, and you do not treat the depression, but you treat the substance use disorder, there's a higher chance that the patient will continue to struggle with relapses of the substance use. Now, there's two different types of care models. One is the continuum of care model, in which we start with the lowest level of care and step it up as needed. Whereas the other one, which is my choice of thinking, is the chronic care model, where you assume that once an SUD or mental health disorder has been established, think more of it like diabetes or hypertension, that it will continue forever and you have to actively guard against it. This shifts your mindset, including the patient, to the idea of early intervention, prevention, and promotion of health rather than just responding to ill health or crisis. Lastly, another approach, that is the broadening of the base approach, is a very interesting one, where you don't wait for the disorder to show up, but you actually proactively seek it. You broaden the base of the population that may be at risk. You pick it up by using screening, early referrals. You involve schools and other places which can pick up and attend to potential problems. Many of us know of different stories where a certain type of screening resulted in picking up something entirely far away. For example, picking up ongoing undeclared domestic violence through just conducting a suicide screen. That is another care model that can improve overall population outcomes. Now, a few words on organizing yourself. How to measure outcomes is absolutely necessary. Truly, an ultimate outcome would be a full recovery of mental illness and a complete abstinence from substance. Settings such as these can often be recipes for disappointment, more intense struggle, and the sense of failure ensuing early on. This approach has to be replaced with a harm reduction model. Instead of thinking ultimate goals, we need to step down those goals. And often people ask, how will I organize myself around that? Well, you can break them down into these categories. So reduction of use, substance use, or having to reduce the need for medication. Increased level of functioning, the person picks up a job or something. Improved disease management, the person is more able to reach out and attend various necessary interventions. And then, for example, movement through the stages of change. So you look at the stages of change and look at the reduction of the internal and external harm, and you rate the person's improvement based on those little steps. Well, I'll show you a slide to just help you remind those. And then finally, reduction of overall service use, and lastly, movement to a lower level of care. These are all good small goals, and they can be separately thought of, and you may find that the patient is succeeding in some of them very well. And that can be a very positive reinforcement for continued attempt at treatment and recovery. So let's move on to talk about a comprehensive approach. A great model is the Comprehensive Continuous Integrated System of Care model, CCISC. It has some principles. It was originally presented by Minkoff, and it has also been used in Massachusetts. The principles are something like this. You want to think that dual diagnosis is an expectation, is the rule rather than exception. The second principle is that each individual is different. ICOPSD stands for individual with co-occurring psychiatric and substance use disorder. C, the SAMHSA's 4-quadrant model looking at severity of chemical dependency and severity of mental health. This model can help you place a combination of the burden level and figure out where the person stands. This is a very simplistic model, and you can have more elaborate models. The principle number C is that empathic, hopeful, integrated treatment relationships, and I want to emphasize relationships, are the most important contribution. D, case management and balancing the needs is extremely important. So a person with, for example, a serious persisting mental illness, SPMI, or sometimes they say SMI, serious mental illness, may have very different needs for the one who has a low mental illness and a higher substance use disorder. Now, guiding your interventions and their successes are by looking at all the approaches: the disease model, the recovery model, the phases of recovery, and the stages of change. And then one last principle that it emphasizes is that you have to develop practical outcomes. For example, the things that I just discussed a few minutes earlier, that your targets should be smaller, divided into many pieces, and concrete. So now let's move on to kind of summarize and conclude our treatment section. Basically, the idea is of individualizing care. Many times it is easy to say, provide individualized treatment plans. And one wonders how. What does it really mean? It's so easy to say it. Well, take a look at this pie. Look at each individual slice. If you can analyze the patient from each one of these perspectives, each one of those slices, and can then figure out for each one of them what kind of a treatment plan I require, the combination of all those would end up becoming an individualized comprehensive treatment plan. For example, start with the diagnosis, then use SAMHSA's 4 quadrants for severity, then take a look at stages of change, the recovery phase the patient is in, the level of care which is needed now, what are the external factors that influence positively or negatively the whole situation, and what is the level of function of the patient and where it needs to go. That will help you develop an individualized care plan. Now, just to help you remind, the stages of change are often mixed up with recovery phases. Stages of change are pre-contemplation, contemplation, preparation, action, maintenance, and hopefully after maintenance one day an exit out of that illness. And whereas the recovery phases are that when you have a patient at any given point, you have to identify which phase they're in. So is the person in an active treatment phase, or is the person now actually not in need of active treatment, he's just preventing relapse? These things can help you tailor the current approach. What do you need to do? This is also very helpful for documentation purposes. If you can take the whole pie and write a one line about what you're trying to do, what's your analysis of the piece of the pie or the slice of the pie, and what you want to do with it, and your documentation will be fine. So now let's just come to the conclusion of the whole thing. I would just say these points in summary. There's a lot to learn more. Co-occurrence may actually be driven by a similar etiology rather than one of them causing the other. Also, consider co-occurrence as the rule, especially when you see a patient with substance use, and I would recommend to suspect it highly when you see a patient with a mental health disorder who may have as a small substance use disorder, which could be just nicotine or marijuana on the surface. Treat both of the disorders at the same time and consider both of them as primary. Get the system to connect all pieces of integration. If you don't have a truly fully integrated system, it could be still possible that the team members who are working get together a care team. They set up a care team, and it's quite possible in electronic health records such as Epic. Get them to be involved and have one of the persons in the system drive the connection rather than lean it as a burden on the patient. Again, make individualized treatment plans and make smaller concrete goals. So now we conclude this. Thank you very much for listening to me. I hope this was helpful. It is a very dry subject sometimes when you're talking about neurotransmitters and neural connections. But let's hope it works for you, and please feel free to email me with any questions or suggestions. All the best. Thank you again.